Welcome to another CME session from SJMC. We hope you enjoy the content.
Hello, everybody, and welcome to another Saturday afternoon. And with us today is our esteemed panel, chairperson, Dr. Jayamala, and panelists, Dr. Shamrus and Dr. Yap. So, welcome, team. And the topic today is on hypertension, when to treat first and when to watch. So, I hope you all will stay with us until the end of the webinar, where there will be Q&A, and we would welcome questions in Slido. So, please join us in slido.com. If you have the Slido app on your mobile, you just enter the code 4241483, or if you scan with your QR code scanner, it will take you to Slido and the event. If you're watching in the DOPS SJMC CME page, the Slido is already embedded in the same page, so you can post your questions there. We will show you the registration link for how to claim the CMB point at the end of the session. So without further ado, I will pass over to Jayamala. We'll start the session. Over to you. Yeah.
Thank you very much, Alan. Very good afternoon to all of you. And thank you very much for joining us on the 29th SJMC Cardiology Grand Rounds. As Alan mentioned, we are talking on a very common topic, hypertension. When to treat first and when to watch. Okay. As usual, ours is a case-based approach, and I will start by presenting the first case. My patient is a 33-year-old young man. He comes to see the doctor with headache and neck pain of 3 days. Cannot sleep, highly stressed in his job in an advertising firm, trying very hard to meet deadlines. No previous medical illness, not been on any medications, no time to exercise, smokes 20 cigarettes a day, and both his parents had high blood pressure, but in their 60s. On examination, he's not really weight, so his BMI is 26. There's a resting tachycardia of 90, and the blood pressure you measured is 160/90. Clinically, no left ventricular hypertrophy, dual rhythm, lungs are clear, and fundus are normal. Okay, Shamrus, maybe you can very quickly revise with the audience the proper steps to be taken in measuring blood pressure.
Okay. Hi, everyone. Thanks again for joining us. So I think we've all been aware with regards to how you should measure blood pressure properly in the clinic settings. So it should be done in a appropriately quiet room, reasonably temperature, and then patients should be rested for at least half an hour, 5 minutes before you take the blood pressure, but they shouldn't have had caffeine, cigarettes, eating, alcohol, for at least half an hour before you take the blood pressure. Make sure the bladder is empty, they're seated on a proper chair with a proper back support, feet rested on the ground, uncrossed, bladder emptied, and then the arm should be rested on the table at the heart level. And then make sure you use a well-validated BP machine with a proper cuff size. And then you should measure the blood pressure at 1 minute intervals, usually recommended 3 readings, and you take the average of the last 2 readings. This is what we normally should ideally do in a clinic setting to get a proper reading.
Can I ask you, Shamrus, how long, the arm is like this, how much of the arm should this cuff cover? Because often I see the cuff is right down here.
Yeah. So basically, it's above the band of the elbow. You should measure at least 2/3, of your arm level, you see. Because sometimes you don't really have time to measure the circumference. So I think the rough estimate is 2/3 at least of the arm span.
Important that you learn, you have a proper cup size, and the patient is well rested before you measure. Okay, now Shamras again. So see, if a person presents to you with an elevated blood pressure, like our young man,
Yep. Okay, so like any other medical condition, I mean, you take a proper history and do a proper examination. So someone young like him, you would want to know whether there are any symptoms and signs that are maybe suggestive of secondary causes for hypertension. I think this is important to identify. And after that, you usually, for all of us, we should measure the 10-year risk, cardiovascular risk factors, but usually that's validated for 40 years and above. I mean, someone young like him, you can maybe then look for any evidence of target organ damage. You can maybe check the urine, do an ECG, further assessment to see whether there are any signs and symptoms that are suggestive of real hypertension here.
so what do you do for this patient, Shamras?
So for this man, I mean, he's quite young, but on the other hand, he did have an elevated blood pressure readings in clinic. He's a smoker. He has an elevated BMI, and there's also a family history of hypertension. But because he's so young, I would really tell him to embark on strict lifestyle modifications first. Maybe start exercising more, reduce the salt intake in his diet, as well as try and lose some weight and stop smoking. And then ask him to maybe monitor his blood pressure regularly, maybe twice a day for at least 1 or 2 weeks, and come to clinic in 1 to 4 weeks interval to recheck his blood pressure. I wouldn't start any medication at this point.
So, this is him. So these are the tests which are done. First office visit 160/90, as I told you. Hemoglobin 16.9, creatinine is 84, sugar 5.2, the cholesterol is as shown, and the urine ECR is about 20. So 22 milligram per albumin per millimole serum, a urine creatinine. So why do a urine albumin creatinine ratio? Why not just a dipstick for urine protein, Shamras?
Okay, so generally urine dipstick has a lot of false negatives and false positives, and it can be affected by various factors such as your diet, exercise status. So it's not very accurate to reflect true proteinuria. And ACR apparently has been associated with early microangiopathy in the kidneys and has been shown to have higher sensitivity and specificity for proteinuria. And it has also a very high negative predictive value as well. So it's usually preferable to do ACR compared to your simple urine dipstick to really assess for proteinuria as a marker of target organ damage in hypertension.
Results you manage this patient, is it any different from what you have just told you earlier?
Not at this point. I mean, I would really ask him to go with the lifestyle modification first. Was the urine ACR elevated? I mean, I wasn't quite sure. I mean, if it's elevated, I would probably want to do further imaging assessment for the kidneys as necessary. But other than that, I will just ask him to come back with a proper home BP monitoring and a BP diary to recheck his blood pressure in clinics, maybe at 1 to 4 weeks interval.
What much would you expect the BP to be reduced?
I mean, in general, strict lifestyle modifications have been shown to reduce your blood pressure by an average, I mean, minimum 4 millimeter mercury to a maximum of maybe 11 millimeter mercury, especially with the DASH diet. So you can expect reduction in that kind of range, but you have to be disciplined and, do it persistently. If once you stop doing your lifestyle modifications, your blood pressure will go back up.
Okay. So after that period, the first visit, he was advised to rest and he went back to his hometown, spent a few days with his family, and came back to see you a week later. The heart rate now is down to 78 and the blood pressure is 130/85 times 2. What times you checked? What will your advice be to him now, Dr. Yap?
So this is interesting because this patient had a rest and obviously de-stressed from his work, and his BP came down to relatively normal levels. So I think this is not an uncommon scenario actually to see in the clinic. Usually I would discuss with the patient about lifestyle modification, how to reduce work stress, so that they can maybe sleep better, and reducing stress and improving sleep often will improve their BP measurements.
He followed your advice, but then he went back to work. And a week later, he returns. Headache. BP, 170/95. So what are you going to advise him now?
Well, again, it's something that I've come across a few times in clinic where when they are working very hard, the patients tend to run a higher BP. So now the options, I mean, obviously for most people, we can't just discontinue work. The option is, again, managing stress at work, seeing whether there are any ways, talk to the manager and see whether there's any way to reduce the stress level, number one. Number two is probably to consider using some medication. And sometimes patients, they do request for blood pressure lowering medications, and sometimes patients also request for sedation to help them sleep at night. So those are the options.
Is there a place for intermittent therapy? Because you did mention that sometimes patients ask for medicines for their blood pressure. So when the blood pressure goes up, we take it. So is there really a place for this intermittent therapy?
If we follow the guidelines, there isn't. And what I would do if we are following guidelines is actually take BP measurements. And if this patient has a BP diary at home and they're going through all these periods of stress and their BP measurement is actually in the recommended level to start medication, then I would do. However, practically, this may not be true all the time. So yes, I do sometimes give patients medication and I ask them to go on standby, because if their BP is high at home, especially let's say in the evening, and they don't have any medication to hand, then they will come to emergency, and it's a very disruptive thing for their life to come to emergency for high BP at home. So I would prefer to give them some standby BP medication, for example, like Ambulatory 5 milligrams. And if their BP is high, ask them to take the medication.
I guess this is off-label use of BP medication. But sometimes I think it is substituting for a sedation. So if you don't give them anything, they get more stressed and the BP goes up to you. Okay. My second patient is exactly the same like that. Okay. 33 years old, smokers, parents also have blood pressure, weight all the same. BP is also 90, and he also has a tachycardia. And this is his profile. Okay. HbA this time his creatinine is 160 with an EGFR of 50. Sugar, lipid profile the same. Urine ACR is 400. Okay, anything above 30 is abnormal, and above 300 is macroalbumin. So, Shamrus, what would you do for this patient? The last
So, I
patient you said,
mean,
watch first. This patient,
yeah, again, this is another chap. I mean, he's young, but he has evidence of target organ damage in terms of kidney and proteinuria, but he hasn't got any other overt risk factors that I'm aware of. I mean, you can again embark on strict lifestyle modifications, but some doctors may choose to consider things like ACE, ARB in someone like this with regards to proteinuria to better manage the proteinuria as well as the blood pressure. But I mean, I don't know. I mean, if he really can change his lifestyle, again, you can monitor and repeat maybe more frequently earlier TCA in clinic and see whether there's any changes in terms of the urine protein ratio. What did you do for this patient, Dr. Jaya? I'm not sure.
this patient, I decided to start treatment early because he already has proteinuria and BP, his kidney wasn't so good. So
Yeah.
this I started even at the first visit because
Okay.
I was very worried about his kidneys.
Okay.
He's only 33 years old. Whether the blood pressure is the cause of kidney problem or whether it's the result of the kidney problem, some kidney disease, I don't know. But I think the elevated blood pressure is going to make the kidney function worse. So I decided to start treatment early. What about you? Yeah, would you have done that?
Yeah, I have done the same on the basis of evidence of target organ damage, proteinuria, renal impairment. I think I would start using medication.
Probably get the
I can't
nephrologist
even-
also to have a look at him.
Sorry, Dr. Shamrus, you were saying something?
No, I was just commenting maybe we should get the nephrologist also to have a look at him to check the kidney dysfunction further.
Sure, yes. Your point is well taken, Shamrus. Okay, the next case is by Dr. Yap.
Okay, thanks. I have two cases to present. This is the first case. This is a 48-year-old man who I saw in clinic. He came to the clinic because he was concerned about blood pressure. Both his parents had high blood pressure and he's reaching middle age already. He has no previous medical history. He's not on any medication and he doesn't smoke, but he has a family history of hypertension. So his BP in the clinic is 140/90 and a normal heart rate. So from the clinic, we do some initial tests, ECG, some blood tests, urine tests, and I asked him to do a BP diary at home. So the blood tests show that he has normal renal function, cholesterol 4.3, LDL 2.6, so not elevated, and his urine analysis shows no protein, and we screen for diabetes as well, so no sugar. So all quite clear so far. And his ECG shows normal sinus rhythm. So he goes back and does a BP diary. As you can see, this was a case from recently. This is the actual patient's diary. And I asked him to do 2 readings a day, one in the morning and one in the evening. So these are the numbers we are getting. They range from 1 2 something and occasionally going up to 1 4 something. Okay, so with regards to BP diary and home BP monitoring, Dr. Jaya, how would you advise your patient usually?
Basically, firstly, you have to tell them that the cutoff for the home blood pressure is not 140/90, but 135/85. So it is about 5 mm both for systolic and diastolic lower than the office blood pressure. The way of measuring the blood pressure is almost exactly the same as what Dr. Shamrus had pointed earlier, resting, seated properly, and having a proper cup size, and having your hand resting on a table. It's better to use a BP cuff rather than the one at the wrist. The one at the wrist is generally not well validated. And how often to measure? This is what the ISH, the International Society of Hypertension, have advocated. Before each visit to the health professional, 3 to 7 days monitoring in the morning, before the drug intake, and in the evening. Measurements on each occasion after 5 minutes sitting rest and 1 minute between measurements. For long-term follow-up, 1 to 2 measurements per week or month, depending on how good your control is. Can I ask you, Dato' Yap, how did you get this average home blood pressure? You came up with this average home BP.
Yeah, so if we take the chart and we split the systolic and diastolic readings. So what I did is, if you look at the top 143, 125, and we keep going down, I type all these numbers into a Excel or calculator, and then I would divide them by the same number of readings. So if there are 10 readings, you divide it by 10, then you will get an average systolic pressure. Then we do the same for the diastolic. So the diastolic readings divided by the number of two readings, you get the average number. So this patient's home BP diary, we did a calculation, was 136 over 90. So
this is higher than the norm. You can say that he's hypertensive.
Yeah, because according to the guideline, between 130 to 140 systolic, for example, will be stage 1 hypertension. So, Dr. Jaya, should we start medication?
I probably would not. Though like I pointed to you, the home BP is 135/85. It is elevated. I would start with non-pharmacological measures at this present moment in time and still monitor the blood pressure. This patient doesn't have any target organ damage, so I probably will still choose.
Yeah, I agree, and that's what most of us would do. But actually, for a sort of exercise to actually justify this correctly, then what we can do is to follow the guidelines by doing a 10-year cardiovascular risk calculation. Now, if you type into Google, there are different electronic calculators that you can use quite easily. And what they do is, as shown here, ask for an input of the age, the systolic blood pressure. So in this case, we put in the average home BP reading, the total cholesterol, HDL, and whether the patient is on BP medication, smoker, or diabetic. And in this case, we got a number of 8%, which is less than 10%. So in the next slide, this slide is actually the 2017 AHA guideline. I just pick out the very simple guide, which I think is relevant to all of us. So if you have stage 1 hypertension and stage 2 hypertension, here is the guide. So anyone with stage 2 hypertension, BP, or in this case, if you're looking at average home BP is more than 140 systolic, then we should start medication. Now, our patient had a BP of 136, so this is within the stage 1 hypertension group, in which case you should need to start medication if they have a greater than 10%, 10-year cardiovascular risk. And that's what we can calculate from the calculator. Okay, in this case, we didn't have more than 10%. And in general, you can roughly know that if a patient has high dyslipidemia, diabetes, and they are a smoker, and they are older, then they are more likely to fall into the higher than 10% risk group, in which case they are more likely to need medication. So in this case, we did not start the patient on medication. Okay, so we can go to the next case. This is my second case. It's a 61-year-old lady whose BP also at home has been a bit borderline 130 to 140. She has a history of dyslipidemia and diabetes, and she's on diabetic medications, Jardiance and Janumet. So in the clinic, her BP is actually 145/95. And so again, in the clinic, we start to do some blood tests, ECG. But I had a discussion with the patient because I always ask them to do BP monitoring at home. But she said, no, I don't have time. I'm too busy. I've got so many things to do at home, and I have to work and then to fetch the children and all these things. So she said, what other options do you have? I said, okay, we can do a 24-hour ambulatory BP. Hello? I call you back 10 in a second, in a few minutes. Yeah. 10. Yeah. Okay, so her initial tests show that blood count and renal function is normal. Cholesterol is elevated, 6.2. HbA1c is elevated, and 7.5%. She has no protein in the urine, but she has some glucose in the urine. ECG again shows nothing significant. She has a normal sinus rhythm. And so we did a 24-hour blood pressure measurement, and this is the actual graph. You can see over 24 hours. The line, the red line shows upper limit, which is 140. And then over the time of the night, you will see that actually the BP dips. So during the day, it's kind of borderline slightly high. But at night, when the patient sleeps, the BP then goes lower. So this is the trend that we will normally see. So now, Mr. Shamrus, when would you decide to do ambulatory 24-hour BP or home BP monitoring, and maybe you can discuss which of these have some advantages?
Okay. I mean, both can be used. Ambulatory BP, first of all, whether it's available or not. Not all centers have ambulatory BP measurement. Home BP monitoring is widely available. Any patients can just buy a validated BP machine and do it at home. Ambulatory BP looks at hour-to-hour variation of your blood pressure in one particular day. So it can be affected on what the patient was doing on that particular day. Whereas home BP will look at several days over longer duration, maybe reflecting a more accurate and more reproducible BP measurements. And some patients don't tolerate the ambulatory BP very well. They don't like that it's a repeated measurement. So what tends to happen is they take the cuff off. They will wear it for maybe 12 hours. And when they sleep at night, they will take it off. So the readings won't be accurate. But the good thing about ambulatory BP, it can recognize this deeper, non-deeper pattern. It can even diagnose nocturnal hypertension. It can diagnose mass hypertension as well as white coat hypertension, which can also be detected by home BP monitoring. So I guess you can discuss with the patients and see what they prefer. Nowadays, from my own practice, I tend to use more home BP monitoring because it's widely available and I find the results are more reproducible. I don't know about Dr. Jaya or Dr. Yap.
I also tend to use more home BP monitoring, although at sometimes you may have to ask your patient to bring his blood pressure to the office for you to validate whether it is reliable or not. Sometimes the BP machine may be out completely. So what I do is I measure the office BP and he measures it on his machine, and if it's quite close, then we know it is reliable.
Yeah.
What about you?
It's advisable to bring the machine at least once a year.
I think there are a couple of issues. One is a cost issue and the other is a practical issue. So of course, doing an ambulatory BP, there's a charge, the hospital will charge. And whilst if you actually do a home BP, it's free. So in most cases, will end up doing, home BP. But there are some people that we are still not very sure whether the home BP measurements are done correctly, or they are very inconsistent, the patient forgets. Then in this patient, maybe the ambulatory BP is a good idea. But I think Dr. Shamrus is right in the sense that there are some patients that don't find this very convenient because the BP cuff keeps inflating on a regular basis, and if it's tight or something, then it will disturb the patient's sleep. So if it disturbs the patient's sleep, the BP may show up as high. So there are still some practical issues for ambulatory BP. Sometimes I work on that. I tend to do it as an inpatient. So the cost is maybe covered by insurance, and they are actually in hospital. So it seems to overcome some of the practical issues. So we got the result of this patient's 24-hour BP in numbers. Just now I showed you the chart. So the machine actually will now calculate for you. You don't need to calculate yourself. So I show you just the average BP of all the readings is 137/78. So we just need this number. So we can ask Dr. Shamrus, would you start this patient on medication?
I probably wouldn't at this point. I know the level achieved on the ABP was above the cutoff, but I don't see any evidence for end organ damage, even though the patient had diabetes. I would probably embark on, again, strict lifestyle modifications, ask the patient to monitor the BP more frequently at home, and see the patient earlier at clinic TCA and decide whether at some point the patient will need medication or not, but not at this point.
Actually, I did start medication, but I think this is a bit of a gray area when you look at guidelines, because without this patient, without actually calculating her risk, I think due to the fact that she has this lipidemia and diabetes and stage 1 hypertension, I felt that probably it's worth to start. There's no harm to treat, even though it's not a very high BP. So Dr. Jaya, what would you do?
I agree with you. This patient has many risk factors. I mean, she's diabetic, she's got a dyslipidemia, her diabetes is not well controlled, and she's not young, she's over 61. But I agree with Shamrus, but probably will not want to start at this point in time. So what does the guidelines tell us? Well, now it is interesting, and I put it up here, that the guidelines actually started with 2014, the 8JNC. At that time, they said if you have between the age of 18 to 59 years, the target blood pressure should be less than 140/90. Then, as we go through the spring trial, results came out, people began to bring it down to 130/80, 130/80. And interestingly, over the last year, both the NICE and the American Academy of Family Physicians again have put it up to less than 140. So it seems that we have gone one big circle. And it's the same for the older people as well. It tends to be more lenient to about more than 150/90. Why? Why did they start to look at it and say, why don't we have a lower blood pressure? Well, this is data from the American Academy of Family Physicians. And when they looked at all-cause mortality, CV-related mortality, stroke, serious adverse events, other adverse events, in terms of benefit, really, there was benefit. No benefit, except for maybe a slight reduction in terms of myocardial infarction, 0.84, with the with the confidence intervals just less than 1. But in everything else, it crossed 1. So it was no benefit. Whereas if you look at adverse events, especially serious adverse events, it was more. So that is one of the reasons they backpedaled to 140/90. So if you look at, according to diabetes, well, again, look at the year. JNC8, they all first started off with 140/90. Then in 2017, 2018, for diabetics, both the Americans and the ESC brought it down to 130/80. And in fact, they said that the ESC said that you may even consider 120/70 in diabetes. And then came NICE and the ADA, ES later part. NICE said 190. In fact, the most recent NICE I will share with you later. American Diabetic Association, last year, 2022, diabetes target less than 140. Diabetics with high CV risk. And who did they say a high CV risk? Patients who already have atherosclerotic cardiovascular disease. That means coronary artery disease, stroke, or peripheral vascular disease. Or a 10-year ASCVD risk of more than 15%. Remember earlier on, Yap shared with you that it should be more than 10%, but now it has to be more than 15%, and then they would consider less than 130/80. What does the NICE say? This is from 2023, last edition. BP targets in patients with type 2 diabetes, age less than 80, clinic BP of less than 140/90, home BP less than 135/85. In people with CKD and diabetes, and also in patients with an ACR of more than 70 milligram per millimoles, try to aim for a systolic less than 130 and a diastolic less than 80. So basically, if you don't have CKD and you don't have atherosclerotic cardiovascular disease, it appears that the current guidelines seem to say that even in type 2 diabetes, just aim for less than 140. If you're more than 180, NICE says less than 159. Okay, so guidelines change, and guidelines change according to the way evidence goes and how data is analyzed. So sometimes we need to keep studying and learning just to remain current and make sure our practice is not outdated, or the patient himself will turn around and say, the latest guidelines say that you don't need to treat me. And then we are stuck. Okay, the next and last case, we got a lot of times, it appears, is the last patient by Dr. Shamrus.
Okay, so this was a 38-year-old female patient, married. She was a non-smoker, didn't drink any alcohol. BMI was at 24.7. She's a known case of breast cancer with liver metastasis, diagnosed in April 2020, completed her surgery and treatment by June 2021. She had a recurrent small liver mets on PET scan in October 2021. She was started on IV Kadcyla treatment then by her oncologist, and by November 2022, they found no more mets on repeated scans, and she was maintained on IV Kadcyla. It's called maintenance dose. Family history of hypertension in father and brother, no known allergies, no other regular medications, no other recreational drugs usage. So her blood pressure trend noticed to be on the high side by her oncologist. Every time she comes to the chemo daycare, they will measure her blood pressure, and they notice a trend between 130 to 140 systolic, diastolic 80 to 90. So she was informed that her hypertension could be related to her IV Kadcyla treatment. She was actually referred for hypertension management in March, early this year, basically. Claims her BP trend at home tend to be between 130 to 140, 80 to 90. Next.
What is this IV Kadcyla? Can you please try to educate me a bit, Dr. Shamrus?
So I'm not an oncologist, so I Googled it earlier. So IV Kadcyla is a new type of cancer treatment. Basically, it's in two-in-one medication. So it has a similar monoclonal antibody as Herceptin, but it also has a chemotherapy agent in it. So it's mostly for metastasis breast cancer. I think it's been used. So patient will come to chemo daycare for IV infusion of this medication, but it has certain risk factors associated with it. I mean, it can cause cardiac toxicity. It can also, I mean, it has been shown to have association with elevated blood pressure as well. So on examination in my clinic that day, her blood pressure was 140/80. Other than that, there were no other significant findings. Her initial tests also showed normal blood count, normal renal function, ECG sinus rhythm, query maybe borderline voltage criteria for LVH. Chest X-ray was normal. Her echo was done subsequently, showed no LVH with normal LV systolic function, and her urinalysis showed no protein. So what happened? This is her ECG. I mean, Yap, you want to comment on it? I mean,
Yeah, sinus rhythm. We are looking out for LVH. The QRS complexes are a little bit tall, but they often
nothing
look a
too
little bit
overt, yeah.
So go for
Okay.
echo to look for LVH.
Yep. So echo was done and there was no LVH. Yeah.
Can I ask, since we are lots of time, how did you measure LVH? Would you like to just revise with your audience how you would measure LVH, Dr. Yap, on this ECG?
Yeah, we are looking for, I think what I follow is so-called, there are different criteria. The one that I've been using for a long time is so-called criteria. So if you look at the V1 and V2 or the V5 and V6, and you take the biggest compass in either V5 or V6 here, where you are pointing at, and we look at the big squares. So here I can see about 3.5 big squares, and we then add it to V1 and V2, whichever one is the bigger. So there we can see about 4 squares. So now the criteria is if you have bigger than 7 squares, then it fits the electrographic criteria for LVH. So in this case, it just reaches 7 squares, more than 7 squares.
Okay. So yeah, so what would you do, Dato' Yap? I mean, for this patient?
So I see this case as a little bit like Dr. Jana's case, where there is a precipitant in some way. In that case, was a stress from work, and in this case, there seemed to be a oncology medication. But of course, the difference is that here this patient has a significant illness, and that becomes a slight difficulty if you try to advise the patient to stop the medication. So we have two options. One is take off the medication which is causing the blood pressure, elevated blood pressure. And then the other option is to start a blood pressure medicine in tandem. So you've got one medicine making the blood pressure a bit high, but another medicine controlling the blood pressure. So obviously, there's no straightforward answer. I think here we need to have a discussion with the oncologist as well as the patient. And again, I have actually been through this scenario before. We generally do a little bit more monitoring and have a further discussion, and then make a joint decision whether to start the blood pressure medication on.
Okay. So yeah, the question is treatment or not. I mean, she's very young and no other risk factors and no evidence of target organ damage, but on a treatment that can elevate her blood pressure. And the question is whether we can stop that treatment that is causing her hypertension. So at the time, patient was not keen on any BP medication. I mean, she claims her diet was not too salty. She does regular exercise. Weight was okay. Was not stressful at work. But maybe she can cut down a little bit more salt in her diet. She wasn't keen on any tablet for her hypertension at that point. Would like to continue with BP monitoring and further lifestyle modifications. So, yeah, is this okay?
The reasonable decision, as I said, I think a lot of it is discussion with the patient and agreeing with the way forward. So doing some lifestyle modification will reduce the BP, improve it slightly. And then you said that we're going to do further monitoring, which I think is the thing to do, because if we have demonstrated still elevated blood pressures, then another rediscussion probably will be beneficial about starting medication.
Okay. Personally, I was a bit worried because I don't see much space in terms of her lifestyle modifications because I thought she was quite good already at that point. And the issue was her IV Kadcyla, which couldn't be stopped. So what happened? She was admitted 2 months later via chemo daycare with an elevated blood pressure of 180/100. See, the oncologist discussed other treatment options for her breast cancer in view of her elevated blood pressure with IV Kadcyla, but she declined to change any therapy because she's meds free at the moment. Remember, she had recurrent meds in the past. She's very anxious about that fact, and she didn't want her meds to come back after stopping IV Kadcyla. So, I mean, in the end, she agreed to be started on BP medication, and since then, her blood pressure has been very stable. The issue was when she didn't want to start her blood pressure medication initially, she was supposed to come to clinic regularly and to monitor her blood pressure regularly at home, but she didn't do that. So I think if you did do it, she would have noticed the blood pressure trend climbing slowly and maybe come earlier to clinic and preventing the admission via chemo daycare with such marked elevation in her blood pressure.
So agree that even if you have one BP reading above 180, 110, then you can start treatment straight away. You don't need to monitor. So
Yeah.
when this lady came with 180, 100, I agree with you that it's justifiable to have started treatment straight away. Okay, so what are the lessons that we have learned from these few cases that we have presented? Firstly, before a diagnosis of hypertension can be made, you must have more than one BP readings. You can either do this by serial office visits and complement it with either home BP measurements and keep a BP diary, as Dr. Yap has pointed out, and you can calculate the average BP, and that would help you make a decision. Or you could do the ambulatory blood pressure recording, which is a bit more expensive. It gives their pros and cons about each of home BP versus ambulatory blood pressure. These are the different ways you have to really establish, does your patient really have blood pressure or not? And in managing hypertension, of course, the first step is always non-pharmacological measures. Don't expect big changes. As Dr. Chambers has pointed out, the decrease is very modest. It may be anything from -3 to -11, small. And antihypertensive medications are initiated, as my colleagues have pointed out, depending on level of blood pressure. The blood pressure is very high, 180, 110, start away, straight away. The presence of target organ damage, like our second patient. And the severe risk of the individual, as Dr. Yap has pointed out. The old AHA guidelines, they say the 10-year risk of more than 10%. They have not revised that guidelines yet. I think, as Yap pointed out, it's about 2017. ADA have revised their 10-year risk to 15% in their diabetic patients. So I guess we have to wait to see when the Americans come up with their next revision. The target BP will again depend upon the patient and CV risk, and a root guide is less than 150/90 in most patients. And in some patients who already have heart disease or a 10-year ASCVD risk of more than 15% as written by the ADA, or have CKD or then you would consider less than 130/80. I put it as 70 because this is what NICE says, but actually once it's above 30 or above 300 milligram per gram, it is already it already indicates that you have macroalbuminuria, which is already indicative. So we have a lot of time for questions and answers. Is there anything that any of my colleagues would like to say before we pass over to Dr. Ellen? Come up with the Q&A. Yep, anything that you'd like to add so far? And Shamrus, is there anything you would like to add?
No, let's just see the Q&A, yeah.
Okay, all right. Okay, back to you, Ellen.
Okay, thanks for staying on. And we've got a couple of questions in slide. If you have questions to add on, don't miss this opportunity to ask our cardiologists. So join us at slido.com, event ID 4241483. So the first question, or rather comment, came in mentioning that monitoring BP line is better than sitting. So comment from the panel.
Okay, maybe I will take that first. There was a recent study, which actually was, from, if I'm not mistaken, the ERIC atherosclerosis risk intervention community. This was a large of patients, just like the Cunningham that they have been monitoring over years. And when there was a retrospective analysis, the data seems to indicate that a supine blood pressure is better predictor of overall cardiovascular complications as compared to a supine or sitting BP. But this is only one study, it's only one analysis so far. The guidelines, which have been going on since many years, have all been advocating sitting blood pressure. So right now, the standard is still sitting blood pressure.
Yeah, I just Googled it. There was a news report from the AHA in September this year about this finding.
Yes, based on the ERIC's community study.
Yeah, but it needs to be replicated from what you say. Right. So, yeah. There's another question. And in light of recent simplicity trials, what is your opinion on the role of renal denervation therapy to overcome multiple antihypertensive drug therapy?
Can I answer this one? Okay, so just a bit of a background on simplicity trials. There were a series of simplicity trials using the Medtronic catheter for renal denervation. And you can note, I think you showed this title here, renal denervation for resistant hypertension. Now, resistant hypertension is different to what we have been discussing in this talk. So the official definition is actually patients who are still hypertensive despite 3 medications. So let's say if I'm on ARB, a calcium channel blocker, and a thiazide diuretic already, so 3, and my BP, my home BP or 24-hour BP is more than 140, then there has been this trial to look at the role of renal denervation. So yeah, we have some experience of using this therapy at SJMC, and we selected a small number of patients where we did the treatment, and they were strictly in the group of resistant hypertension as we have found. So it does work. Does it work to the level where you can reduce your medication or stop altogether? Basically, no. But it does help to improve control. The rest of it is a long story. I think it's not probably the magic treatment that some people regard it, have the impression that it has. But in cases where you are quite desperate and there is very bad resistant hypertension, it is an option to consider. Thank you, Dr.
Third question, do beta blockers still have a role, and which beta blocker to choose?
Chandras, you want to take that?
Yeah, okay. I mean, I've actually had a few cases of hypertensive heart disease with hypertensive cardiomyopathy where, beta blocker is very useful. If they have history of previous ischemic heart disease and they have hypertension, you can consider beta blocker as well. These are the two specific patient population that I will consider beta blocker usage.
I tend to use quite a lot of beta blockers because if you look like the first patient who had this very stress-induced tachycardia, resting tachycardia, BP going up whenever they're under stress, I think this would be an excellent candidate for the use of beta blockers. And the other condition with the other set of people would be a lot of women, especially after the menopause, they tend to go into these periods when they suddenly feel that they're all stressed up and their BP shoots up. When you give them beta blockers, it actually helps them quite a bit. So besides those who have heart failure, as Dr. Shamruz pointed out, I find that a lot of patients who I see, stress seems to be a big component in their course, in their life, and be a contributory to their blood pressure. And I find that beta blockers do wonders. As they grow older, sometimes using beta blockers causes a bit of fatigue. And then you may want to have to revise your antihypertensive medications. Yes, to me, there is a definite role in select patients.
On to the next question. When do we need to consider investigation to exclude secondary hypertension? Any criteria apart from younger age?
Yep.
Yeah, so you're right. I think anyone who is less than 40 to start with considered young with high BP, it would be worth to look at secondary causes of hypertension. So if you go through the things that we normally do, so I certainly, if you say when do we need to consider in someone who has suggestion of the conditions of secondary causes. So if you think about pheochromocytoma, where you have a high catecholamine release, then you will get tachycardic, right? So if the patient has a lot of tachycardia, a lot of palpitations, certainly, and also hypertension, then certainly this is the patient that you would consider looking. And then the other causes, such as Conn syndrome, which is very, very rare to see, that you may pick up that along the routine blood test, they have potassium abnormality, for example, or even Cushing's syndrome. So these are the hints that you get to look for secondary causes. And lastly, we're talking about vascular abnormalities, for example, coarctation of aorta, which is also very rare, but also renal artery stenosis. So for renal artery stenosis, if the patient had some unexplained pulmonary edema, again, this is very rare to see, or renal impairment, then it's a clue to look for secondary cause in a hypertensive patient.
I mean, it always comes back to your history, right?
To control blood pressure be another reason to investigate.
Yeah. So one of the things that I mean, by that, I think you mean more than stage 2 hypertension. So in severe hypertension and in resistant hypertension, certainly we would be expected to do a workup which is more than our usual, home BP, blood BP meds kind of protocol. We would look for secondary causes.
Question, is there any difference measuring BP with the shirt sleeve on or off?
It's supposed to take off everything. You're not supposed to have any shirt. It should be a bare arm. But having said that, a lot of patients come to the clinic wearing tight shirts or tight blouses. So practically, it's sometimes difficult. I think there is a difference, but it must be very, very small.
I remember coming across a Canadian family practice study which showed no difference as long as it's not too thick. But what do I know? I'm only an AI. Yeah. Okay, next question. Any difference between amlodipine and felodipine in terms of side effects?
I mean, no head-to-head study comparing the two, but I personally tend to find that the amount of leg swelling with amlodipine is slightly more than that with felodipine. So if leg swelling is a big problem, then I tend to use a bit more felodipine. But in terms of efficacy, probably not much.
I missed the one comment in between. Is there a role, again, just to confirm, for intermittent antihypertensive therapy?
Yep, you want to say?
I think we probably confused the audience with what we were discussing, but I think the simple answer is yes. In the practical situation, it is reasonable to give a patient standby intermittent antihypertensive drug.
Right. So, but is it generally okay or just certain cases?
I think it's okay as long as your patient understands what the approach should be. So just to clarify that, what I have found very helpful over the years, and having seen many patients coming through, many of my patients under follow-up coming through to ER for hypertension. What I do is I give them amlodipine 5 milligrams or in any other drug if they're already on amlodipine. And I say, look, if your BP is more than 150 when you are measuring it on the routine thing, then by all means take the medication, and that will stop your BP from going up further and you coming from ER into ER, and then there's at least some opportunity for you to come to the clinic, and then we'll discuss further. And by the next day, I will tell them, look, this medicine, since you don't need it on a regular basis, you discontinue it.
Dr. Tesha has a comment about patients where the BP is high if one uses electronic devices, but the BPs are actually normal, and he's saying electronic BPs may be unreliable due to their repeated use.
Okay, I can add something to that. Now, one of the things is, especially women, when you have that electronic BP on and its cuff keeps inflating, they get all excited and the BP tends to go up. And this is especially if it's worse if it is done with nobody talking to them and they are just seated there. The nurse just measures the blood pressure just like that, and then they walk off. So the first reading should never be accepted. Talk to the patient, keep the patient relaxed, and then if you do it done properly, the second and third reading, find that the BP reading comes down. So just one BP reading, come auntie, sit here, check BP. And then the next thing you're out and suddenly this thing inflates, sure the BP. So I think it's the technique and how it is done rather than the BP device that is at fault.
Sometimes we
on the other
come
hand,
across patients their home BP monitoring is so normal, and then they come to the hospital, it's high. What would you advise?
That is, you have to make sure it's not a white coat hypertension. If they don't have any target organ damage, etc., then I would ask them to bring a BP machine and to check it in the face. If the BP is high, just as I am measuring it's high, then maybe they are right. Maybe they do have white hypertension.
Yeah, Dr. Shamrus, you wanted to say something? Sorry.
Yeah, I was just gonna comment on what Dr. Jaya just said, to ask them to bring the BP machine to clinic or hospital and to compare the readings that is really was low at home. You see, you don't know how old was the BP machine, whether it's calibrated or not. Generally, it's advisable to bring a BP machine to clinic once a year to check with the office BP. And I think general advice in terms of BP machine at home, I think it's every 2 yearly you have to calibrate the machine. So these might be some issues as well.
Okay, I think we overshot this. One question from YouTube. The Dr. Leong has asked, is it okay when some doctors stop medicine when the BP was under control for a long time?
Maybe I just answer that. I tell my patients, don't stop medication unless, say, you have lost a lot of weight. If you have lost a lot of weight and the BP comes down, then fair enough, you can stop. Because you can reduce the dose, but I advise them not to stop because you never know when it suddenly goes up again. And before you know it, you may have some sort of a complication such as a atrial fibrillation, unless they keep on monitoring your blood pressure every day or every week or something like that. So I say that to be on the safe side, continue your medication, maybe at a very reduced dose. But I am not very happy when they stop it, unless say they've lost a lot of weight.
Okay, thank you. I think we've come to the end of the Q&A. We've overshot by 5 minutes. This is the part where you can claim your CPT, your CME points for attending. So what you need to do is go to this link. You dobbs.my, you can omit the www if you want, dobbs.my/141023, which is today's date. So it's quite easy. That will take you to a Microsoft form where you enter your details so that they can be uploaded to the MMA portal. The QR code takes you to the same link. Please, this QR code is just to be scanned with a normal QR code scanner, not the MMA app. The MMA has disabled the QR code for getting points directly. This code is just to give you the link in an easy manner. So please visit the link. Now the link will be invalid after 1 hour. So to avoid abuse. And the reason why the MMA QR code system has been suspended is because of abuse as well. Anyway, we'll try to help those of you who have not been able to catch this live. We will try to have an MCQ system so that you can watch the entire thing and then answer some simple MCQs, which will be posted in our bulletin board or web forum. So please, we will announce more information in our DOPS forums in either Facebook or in Telegram. Please do register because we can't keep you informed unless you are a registered DOPS member. And please also subscribe to our YouTube channel so that you'll be informed of when the next upcoming live stream will be. So the attendance will be manually uploaded, so you won't get the points instantly, but you should be able to get it within the next few days or so. So remember, you sign in now. Rather go to the link now and submit your attendance. And this link will not work after around by 4 p.m. Okay, so it'll be valid only until about 4 p.m. All right. So I'd like to thank all the presenters for their excellent overview of hypertension. I think lots of useful tips. I think I've learned a lot as usual. And I hope you guys have. And thank you all for participating and your engaging questions. All right. So I think we will end the stream here. You can still watch it and you still have a chance to submit your attendance as long as it's before 4 p.m. on Saturday, 14th of October. After that, watch out for the link to the MCQs module if we can get it working. So have a nice weekend, everybody, and good day.